Hi, my name is Julio and I'm presenting this question to RD Medicine. Let's begin. To start a question, I would like to read the last sentence. Which of the following is most likely cause of this patient's current condition? We need to identify the cause and I also like to read the alternative to know what the subject is talking about. So combined duct obstruction, decreased bilirubin glucuronidation, episodic intravascular hemolysis, athletic iron overload, impaired hepatocyte bilirubin excretion, and viral hepatocyte infection. So this is talking about gastrointestinal question, and we need to identify the cause. So later on, we need to identify the etiology to solve this question. So now have a general idea. I would like to start to read the whole question. To a 26-old woman comes to the office due to yellowish discoloration of the eyes and darkened urine for the past several days. So it started now. She has no abdominal pain, anorexia, or nausea. The patient has been told a few times that her eyes look yellow in the past. She has no significant medical history other than mild acne vulgaris. The patient started taking oral contraceptives 2 weeks ago. Her father had diabetes mellitus. Her grandfather has heart failure. The patient is a doctoral student and moved to the US from abroad a year ago. Vital signs are normal. Examination shows mild scleral icterus. Laboratory results are as the follows. Liver function studies. Total bilirubin is elevated. Alkaline phosphatase is normal. Here we will have this is AST, that's normal, and ALT is also normal. So urinalysis, we will see that the bilirubin is positive and the urobilinogen is negative. We need to think what this means. So bilirubin positive in the urinalysis means that we will have a elevated direct bilirubin because the direct bilirubin is water soluble, so we'll identify this in the urinalysis. And urobilinogen is for indirect bilirubin. That's a negative. That means it's low. Okay, so continuing, during further evaluation, the sample from a liver biopsy shows dark granular pigments in the hepatocytes. This is an important histopathology that we need to take care to solve our question. Which of the following is most like cause of this patient current condition? To identify this, we need to know which diagnosis each alternatives want to show us. Okay, so letter A, common biliary duct obstruction, is means about cholelithiasis. That's not a condition that our present uh, patient present because alkaline phosphatase is normal. Decreased bilirubin glucuronidation, it's about Klinger-Najjar syndrome or Klinger-Najjar syndrome or Gilbert syndrome. I will talk about these two conditions later on, okay? In the hereditary hyperbilirubinemia. But this means it decreased bilirubin gluconidation will be less UDP enzyme, and these would be cause elevated indirect bilirubin. That's not our case, okay? Letter C, episodic intravascular hemolysis. That's the hemolytic anemia that our patient do not present because the urobilinogen that represent indirect bilirubin, it's a low level. Okay, so letter D, the hepatic iron overload. That's significant hemochromatosis. Our present patient do not present like diabetes or even the skin that's darker than the normal. So the letter D is also not viable. Letter E, that's impaired hepatocyte bilirubin excretion. This analyzes a condition called Durbin-Johnson syndrome. Okay, so this condition I will talk later. It's about the elevated direct bilirubin, and it's a hereditary condition. So let's keep us this alternative. Letter F, viral hepatocyte infection. If we have an infection, the AST and the ALT would be very, very high. And it's a normal for our, it's a normal case in our situation. So the letter F is not correct. So the correct answer is letter E. Okay. Now we will talk about hereditary hyperbilirubinemia. Firstly, the red blood cells, it's taking about 9 days, 90 days, or 3 months to be degraded. In this condition, the red blood cell will transform bilirubin, and bilirubin in the spleen or macrophages will be unconjugated bilirubin. Unconjugated bilirubin will be transformed to unconjugated bilirubin at the liver by the albumin, and inside the liver we have an enzyme called UDT that will be conjugating the bilirubin, and after be conjugated, the liver will excrete the bilirubin to our urine, or even the intestines will reabsorb the intrahepatic circulation or conjugated bilirubin. That's the pathophysiology of the bilirubin. We have few conditions that's related to deficiency of or the bad side of each these pathways. So the first one is a Krieger-Najjar syndrome and Gilbert syndrome. That's are both conditions related to decreases level of the UGT enzyme. Also, we have a Durbin-Johnson syndrome and Rotter syndrome that's related to uh, our enterohepatic circulation, also the excretion. So to differentiate this, we will see that the Krieger-Najjar syndrome we will have much more elevated level of indirect bilirubin, and Gilbert syndrome we will have a more mild elevation of the indirect bilirubin. While the Durbin-Johnson syndrome is talking about the excretion of the conjugated bilirubin. So the conjugated bilirubin will be excreted that not will be possible in the Durbin-Johnson syndrome. And talking about the Rotter syndrome is a defect in the enterohepatic circulation that reabsorb the conjugated bilirubin. Okay, that's how we differentiate these conditions. To diagnose each one, we need to see the clinical presentation, that will be show Jordans. Okay. Also, we will need to see if the patient have any family history that will be show us the hereditary condition. We will need to see if we have a stress such as extenuating exercise or drug use that could be increase the level of bilirubin. Also, in this hereditary hyperbilirubinemia, we will not have signs of hemolysis, such as we will have just normal complete blood count. Reticulocyte count will be also normal, okay? And also we will not have sign of underlying liver disease. So the AST, ALT, alkaline phosphatase will be all normal. Let's talk about these syndromes. While we have the high direct bilirubin, we will have Gilbert syndrome and Krieger-Najjar. To differentiate these two conditions, we need to look at the bilirubin level. We will have the highest bilirubin, direct bilirubin level in the Krieger-Najjar syndrome, and more mild elevation in the Gilbert syndrome. And now talking about the high indirect bilirubin. This occurs in two conditions in the Durbin-Johnson and Hawthorne syndrome. To differentiate these two conditions, we need to see the urine coproporphyrin, that's elevation of this enzyme that we can find in more about the Hawthorne syndrome, and it's a normal in the Durbin-Johnson syndrome. And also we would like to do a liver biopsy that would show us that in the Durbin-Johnson syndrome we will have more glossy black liver and dark granular pigments that would be not happen in the Rotor syndrome. After this, we need to see the management that's majorly supportive to see two of these conditions. Some cases we will need to have the hospitalization and with phototherapy, exchange transfusion, and also plasmapheresis to manage and help this hereditary condition, but majorly it's much more supportive management. To sum all these characteristics, I like to pass for each question that I do about epidemiology, pathophysiology, diagnosis, and management. So talking about hereditary hyperbilirubinemia, we will have much more incident in the babies and young adults. So the pathophysiology is that could be the two mechanisms. The first one is the UDP enzyme that's changed in Krieger-Najjar syndrome and also Gilbert syndrome. And also we will have the mechanism of excretion or absorption of direct bilirubin. That's the excretion is defect in the Durbin-Johnson, and the Rotor syndrome is about defect in the absorption. To diagnose this, we need to have a clinical features such as jaundice, and also we have laboratories results as bilirubin level. We need to know that the management for the both conditions are supportive. Okay, so this is my presentation. Hope that you like it. Thank you very much, and yeah, hope to see you soon.